Assalamu alaikum. Today we are going to discuss managing breech presentation in labor, which is the B part of RCUG Green Top Guideline number 20. This is guideline on mode of delivery and intrapartum management if vaginal breech birth comes in labor, and it does not cover antenatal care or ECV technique, and it is applicable both to term singleton breech presentation in labor, preterm breech presentation in labor, and twin pregnancies with a breech fetus. Which we often encounter when first twin is cephalic and second one is non-cephalic or breech. Breech at term is found in 3 to 4% of cases, and it is more common in case of preterm births, uterine anomalies, fetal anomalies, and nulliparity. Breech baby has higher perinatal risk than cephalic babies, regardless of the mode of delivery. The term breech trial shows that overall there is a declining trend in vaginal breech birth, leading to often associated with reduced skills, and this is leading to increased rates of cesarean section world over. So, how should we counsel at term breech? We should offer ECV to all eligible women at term unless contraindicated, and contraindications have been discussed in the previous guideline. We should counsel on the possible success rate of both ECV and success rate of subsequently having a vaginal normal delivery. There is a small risk of emergency cesarean section associated with the process of ECV, and it has implications on delivery mode. So, to counsel on the mode of delivery, planned cesarean section at 39 weeks or more is seen in 0.5 per thousand of the babies. The perinatal mortality is found in 0.5 per thousand. And in case of planned vaginal breech, perinatal mortality is 2 per thousand, and planned cephalic birth, perinatal mortality is found is 1 in 1,000. Cesarean section reduces mortality mainly by avoiding post 39 week stillbirths, avoiding labor risks, avoiding breech specific risk, only this is unique to breech, and vaginal breech increases low APGAR score, increases short term neonatal morbidity, and there is no proven increased long term disability in case of babies being delivered through vaginal breech extraction. With strict singleton plus selection and skilled staff, vaginal breech may approach safety of a cephalic vaginal birth. Counseling on maternal outcomes. So, successful vaginal birth, maternal risk is lowest. In case of planned cesarean section, maternal risk rises, and in case of emergency cesarean section, maternal risk is the highest because dynamics of surgery change when it is performed in acute emergency situation. 40% of the planned vaginal breech end up in emergency cesarean section, and cesarean section increases future risk of placenta accreta spectrum, surgical complications, and VBAC rupture, which is found in 0.5% of the cases. Individualized counseling is based upon parity, family completion, and surgical risk profile. The important point and catch here to counsel the parents about planned vaginal birth is that 40% will land in emergency cesarean anyway, so this might help in making their mind earlier for other options. Future babies, prior cesarean section is associated with slight increased stillbirth risk in next pregnancy, which may be confounded, and increased uterine rupture risk during VBAC. Antenatal selection, factors affecting safety of vaginal breech birth. Antenatal selection critical for exams. Recommend cesarean section if any of these is present. But if birth weight is more than 3.8 kg, the neck is hyperextended, there is evidence of fetal compromise, anomalous fetus obstructing delivery indicated for other reasons like placenta previa, and small baby less than 10 centile, and footling breech. So these are the cases. The mnemonic is B heads, where we should rather recommend elective cesarean section instead of vaginal breech delivery. Pelvimetry's role is unclear and used in Promoda study but not routine in UK. So B head stands for birth weight more than 3.8 kg, hyperextended neck, evidence of fetal compromise, anomalous fetus obstructing delivery indicated for other reasons, small baby, and footling breech. B heads stands for the indications where we should refuse a vaginal breech birth. Skill of the attendant, a skilled obstetrician is essential, and units without expertise should refer them antenatally. Lack of skill is contraindication to planned vaginal breech, unplanned breech and labor. Management depends upon stage of labor, risk factors, available expertise, and informed consent. So this is a scenario when a patient who was not planned to deliver vaginally came in labor. So key rule is, if advanced labor and active second stage, do not routinely perform a late C-section because this will enhance morbidity. And if time persists, ultrasound scan for neck position should be done. Estimated fetal weight should be assessed, and all units must have protocols for emergency vaginal breech management. Intrapartum management for term breech. Induction is usually not recommended. Oxytocin is given only if epidural is used or contractions are inadequate. Principle is good progress is equal to good fetopelvic proportions. Epidural analgesia effects on success of vaginal breech birth is unclear. Likely increases both intervention and cesarean section rate and may impair effective pushing. Less intervention approach should be opted. Continuous support should be continued, and calm environment be provided to the woman giving birth to vaginal breech baby. Fetal monitoring, continuous electronic fetal monitoring is recommended despite limited evidence. Rationale is that breech is associated with increased risk of cord compression and early hypoxia detection. If abnormal CTG before active second stage is detected, then cesarean section unless buttocks are visible or imminent birth is likely. Fetal scalp or buttock sampling is not recommended. Place of birth, hospital with immediate cesarean section facilities should offer, and routine theatre birth is not required. Water birth contraindication is contraindicated. Now, this routine theatre birth is not required is an important exam catch. For example, in cephalic pregnancies, we often choose the option of in the trial of instruments in operation theatre. So here, this is not a choice. Protocols. Essential components. Strict case selection should be done. Standardized intrapartum protocols should be used, and skilled attendants should perform the birth. Department should be using checklist and conduct simulations to keep the staff ready. The first stage, same as cephalic labor, avoid early ARM, and in case of slow progress, consider cesarean section as it might point to cephalopelvic disproportion. In case of passive second stage, allow descent before pushing. If breech is not visible within 2 hours, consider cesarean section. Active second stage principle, hands-off technique until umbilicus, and assist only if there is poor fetal tone and delay. Authorized in vaginal breech delivery is 5 minutes from buttocks to head and 3 minutes from umbilicus to head. These times are important, and they are important exam checklists. They can come in MCQs. Selective episiotomy only is performed. Delivery technique, semi-recumbent position sequence, spontaneous delivery to scapula, arms to be swept down, locet if knuckle arm, and head, Marisa-Smalley-Wheat maneuver or forceps, and suprapubic pressure for flexion can be considered. Burn-Marshall maneuver has been discouraged. It leads to neck hyperextension risk and a traumatic injury. All four position gives more spontaneous births by enhancing larger pelvic diameters, and maneuvers are possible but require expertise. Convert to dorsal if difficult. Preterm birth, mode of delivery, not routine cesarean section for spontaneous preterm birth, threshold of viability 22 to 22 plus 25 plus 6 weeks, and CN is based upon stage of labor, breech type, fetal condition, skill available. So in case of preterm breeches, cesarean section is not a routine. If it is spontaneous preterm breech and at thresholds of viability, that is 22 to 25 plus 6 weeks, generally the head size is also very small, and the chances of obstruction by after coming head are reduced. So at this gestational window, that is from 22 to 25 plus 6 weeks, that is less than 26 weeks, we can allow preterm breech spontaneous delivery. And our decision will be impacted by at what stage of labor did the patient present, What is the breach type? What is the fetal condition overall, and do we have the skill expertise available? Planned cesarean section, however, is recommended if there is it is iatrogenic preterm delivery and fetal or maternal compromise is there. Head entrapment, in case of vaginal head entrapment, cervical incisions at 2, 6, and 10 o'clock. An important exam point. Cervical incisions are given at 2, 6, and 10 o'clock. And cesarean section, extended uterine incision, J or inverted T is given. Anticolysis can be used. Twin pregnancy with breech. The first twin is breech, then planned cesarean section is recommended. But if spontaneous labor, then individualized decision depends upon dilatation, station, expertise. In case of second twin breech, routine cesarean section is not recommended. Options are vaginal delivery, internal version, and breech extraction. It depends upon the operator's skill. So in case of head entrapment, in case of vaginal breech delivery, cervical incisions at 2, 6, and 10 o'clock can be given. Cesarean section, at time of cesarean section, extended uterine incision, a J or inverted T might need to be given. And tocolysis might be used to allow uterine relaxation and to facilitate delivery. Twin pregnancy with breech. If first twin is breech, then planned cesarean section is recommended because of the risk associated with interlocking twins. But if spontaneous labor, then individualized decision, and it will depend upon dilatation, station, and expertise. In case of second twin breech, routine cesarean is not recommended. Options include vaginal delivery, internal version, and breech extraction. It depends upon the operator's skill. Governance and training. Mandatory simulation training is required. Departmental breech protocols and counseling for checklist. Auditable standards include 100% documented counseling, vaginal breech stress, success rates, neonatal morbidity tracking, 100% staff trained in breech skills. Contraindications to vaginal breech delivery: B heads, that is big baby, hyperextended neck, evidence of fetal compromise, abnormal fetus, delivery otherwise indicated, small baby less than 10 cm, footling breech. And time limits for assistance we have already discussed. Buttocks to head is 5 minutes and umbilicus to head is 3 minutes. So this is the right versus long statement, correct exam rationale. Guideline, RCOG Green Top Guideline number 20B, breech presentation statement. So all women with term breech should be offered ECV unless contraindicated. That's correct. If ECV fails, elective cesarean section is mandatory. That's not correct. Women must be counseled on planned cesarean section versus planned vaginal breech delivery, and risk of ending up in emergency cesarean section is 40%, and choice should be individualized. Planned cesarean section reduces perinatal mortality compared with vaginal breech birth. Yes. The mortality benefit of cesarean section is only due to avoiding breech-specific intrapartum risk. No. The cesarean section also avoids post-39 week stillbirth and labor-related risks seen in all presentations. Planned vaginal breech increases short-term neonatal morbidity but not long-term disability. That's true. Higher low ABGAR and short-term complications, but no proven long-term neuromorbidity. Emergency cesarean section carries less maternal risk than planned cesarean section. That's false. Around 40% of planned vaginal breech births may end up in emergency cesarean. That's true. Prior C-section increases the risk of placenta accreta in future pregnancies. That's true. Pelvimetry is essential before offering vaginal birth is false. Vaginal breech can be offered if fetus has hyperextended neck. That's false. Footling breech is acceptable for planned vaginal birth if labor progresses well. That's false. Estimated fetal weight at 3.8 kg favors elective cesarean. That's true. Fetal weight less than 10 centile supports vaginal breech trial. That's false. Growth restricted fetuses are at risk of higher perinatal risk, and cesarean section is recommended. Vaginal breech should only be offered where skilled attendants are available. That's true. If unplanned breech with advanced second stage late cesarean section is routinely advised, no. Ultrasound assessment of neck and legs should be done if time permits in unplanned breech. Yes. Induction of labor is routinely recommended for term breech. No. Induction is generally not recommended. Oxytocin may be used if epidural is present and contractions are inadequate. Yes. Epidural improves success of vaginal breech birth. No. Continuous CTG is recommended during vaginal breech labor. Yes. Abnormal CTG before active second stage to continue vaginal breech delivery. No. Passive second stage should be allowed before pushing. Yes. If breech is not visible after 2 hours of passive second stage, cesarean section is advised. Yes. Routine traction should be applied once umbilicus appears. No. Assistance is indicated if more than 5 minutes from buttocks to head. Yes. Time thresholds have been discussed. Burns Marshall maneuver is recommended for after coming head. No, it's false. Lorset's maneuver is used for neck alarms. That's true. MCV maneuver, Marisa Smiley Wheat maneuver, or forceps can be used for after coming head. Yes, that's true. Vaginal breech birth should occur in theatre. No. Water birth is acceptable for vaginal breaches. No. Preterm breech in spontaneous labor requires a routine cesarean section. Preterm breech in spontaneous labor. No, it does not require. Preterm breech with fetal compromise requires planned cesarean section. Yes. Head entrapment can be managed with cervical incision at vaginal delivery. Yes. 2, 6 and 10 o'clock rehearsals incision. First twin breech planned cesarean section is usually recommended. Yes. Second twin breech routine cesarean section is recommended. No, it's false. Department should conduct breech simulation training. Yes. And documentation of counseling is an auditable standard. So, timing of offering external cephalic version. Let me hide the question. 30 years old, second gravida, para 1 is found to have frank breech at routine review. No contraindications. She asked when ECV should be offered routinely. So, ECV is generally offered at 37 weeks in multis. Timing of offering ECV in nullipara. 27 years, primary gravida, persistent breech at 36 plus 1 week, uncomplicated pregnancy otherwise, and she wants to maximize the chances of a cephalic birth. Offer ECV with gestation. So this we know is 36 weeks, so option C. Woman has an unsuccessful ECV attempt at 37 plus 2 weeks. She asks the chances that the fetus will turn head down by itself before delivery. So these are 1 to 2%, 3 to 7, 10 to 15, 20 to 25 or 40 to 50%. The chances of spontaneous version are 3 to 7%, option B. A woman has successful ECV at 37 weeks. She asks how often babies flip back to breech. After a successful ECV, 1, 3, 10, 20, 30. So option B, that is 3% will revert back to breech. Impact of ECV on non-cephalic birth. Which statement best reflects the evidence from ECV at term? ECV increases non-cephalic presentation. ECV has no effect on non-cephalic presentation. It reduces non-cephalic presentation at birth. It reduces non-cephalic birth only in nullipara, and it reduces non-cephalic birth only in regional anesthesia. So it reduces non-cephalic presentation at birth. Option C seems to be most plausible. Effect of ECV on cesarean section rate. Fetuses at term undergoes ECV. Which outcome is most consistent with evidence if ECV is successful? Cesarean section likelihood increases. Cesarean section likelihood is unchanged. It reduces only if moxibustion is used, and cesarean section likelihood reduces only if done before 36 weeks. For successful ECV, cesarean section likelihood reduces. So option C is the right one. Labor outcomes after successful ECV compared with spontaneous cephalic presentation. Labor is associated with decreased instrumental delivery, increased cesarean instrumental delivery, increased shoulder dystocia, no difference in operative birth, and reduced fetal distress cesarean. Option B seems to be right. Predictor of success. Which factor most strongly predicts successful ECV? Amniotic index more than 10, breech not engaged, maternal weight less than 65, multiparity, and posterior placenta. Of these, unengaged breech is most strongly associated with vaginal birth. Use of prediction model. A registrar proposes using a prediction calculator to decide which women should not be offered ECV due to low chances of success. Appropriate Calculators should guide eligibility. Appropriate only offer if predicted success is more than 70%. Inappropriate do not use routinely. Appropriate use only for multi-para. Appropriate only for when AFI is less than 10. So the option C seems to be most correct. Best evidence: tocolysis to improve ECV success. Which pharmacology strategy has the best evidence to improve ECV rates? Etoposide, beta mimetics, glycerol trinitrate, nifedipine, oxytocin receptor antagonist in general. Option B, that beta mimetics, is the right option. Thank you so much for being here. Thank you.